Dear friends, colleagues, good afternoon. My task today is to guide you throughout the complexities of the HCV elimination program at the time of COVID. COVID has been such a huge thing in our lives of the last year that it may seem irrelevant to talk about what's happened to the HCV elimination program. But HCV elimination is by itself a big thing. And we were told a few years ago by the WHO that by 2030, we should have diagnosed at least 90% of infections, treated 80% of those diagnosed, and reduced by 2/3 mortality. And even before COVID started and jeopardized our lives, in fact, we were not exactly on track for HCV, at least at the global level. This recent estimate, which was published by the Polaris Observatory, refers to what's happened exactly up to the end of the pre-COVID period, up to the end of 2019. And as you can see, there were a relatively small number out of the 45 high-income countries which were supposed to meet the target of WHO by 2030. Only these few, 8 or 9 countries, including, I am proud to say, Italy, were on target. A few others were relatively delayed and would have been on target by 2040 or 2050. The others were drastically left behind. If you look at it at the global level, 80% of high-income countries before COVID were already not on track to meet the WHO targets. And of these, 2/3 were off track by at least 20 years. So, in fact, the situation was not rosy at the beginning of the pandemics. But, well, I don't think we need to quote numbers. These were drawn just a few weeks ago, and certainly the numbers today are even worse. Amidst this huge tragedy, what's happened to the HCV elimination programs, which were already lagging behind? Take a country like Italy, and Italy, as I told you, was relatively on target to meet the WHO standards by 2030. These are split by month from January to September. And you may recall that Italy was very heavily affected by the pandemics since February into March, April, May. We had the first wave ending in June, and now we are in the middle of the second wave. But what happened during most of 2020 was that the number of patients treated dropped dramatically. About 1/10 of the patients which were treated before COVID were treated during the worst part of the first peak. And then it slowly restarted, but I don't have the updated numbers up to now, but I can tell you that we certainly are not to the pre-COVID numbers, partly because of the screening program, which have not started, and partly because the services have not restarted to the level of efficiency they had before the pandemic. This is not just an Italian phenomenon. This is a global thing. When a physician from 32 different countries were asked online by people from the World Hepatitis Alliance, in fact, 85 out of 132 groups reported no access to testing for HCV. 46 reported that testing facilities were closed, and 66 reported that patients were in fact avoiding testing facilities. There were problems also with treatment access. Many reported that patients were unable to access treatment. And of these, those outside the States reported that patients were avoiding treatment clinics. And they reported also that prioritization of resources for COVID management contributed to decrease the access to treatment. In fact, deferred laboratory testing, deferred imaging when needed, were a major problem, and the need for multi-monthly refills delayed treatment in a sizable proportion of cases. In fact, when one went to analyze the reasons why, many clinic visits were deferred, and there was a certain amount of access by telemedicine, although this was not popular with many of the centers. Certainly, those centers which were dealing with the highest COVID impact were those who were deferring more visits and were using more telemedicine. Screening was also heavily affected, and no screening or a large reduction in screening was reported by many of the centers. So, is this a problem which has been already solved, or is still an ongoing problem? Difficult to say. We cannot make forecasts. There are too many intervening factors. Control measures, vaccines will probably modify the projection of the pandemics. We are hoping to see a slow burn process, but certainly we are still on a peak and valleys type of pandemic in many countries. So certainly we will have to face the problem of the COVID pandemic for at least 1 or 1.5 years, or even more possibly. And we have to prepare, because leaving people with HCV without treatment will have consequences. We tried to calculate for 2 countries, for Italy and for the UK. This one reflects the situation in Italy. Italy is a place where HCV was quite endemic, and we had a huge number of patients already treated. What would happen in terms of delaying treatment for 3 or 6 or 9 or 12 months? And this calculation was made at the beginning of the pandemic. Here is plotted the number, the percentage of patients who potentially were not treated 1 year after the beginning of the pandemic. In blue, you see the number of new patients developing advanced liver disease, and in orange, you see the number of HCV-related deaths. As you can see, the more you delay treatment in most patients, assuming, say, for example, 1 year, the more you'll see patients with advanced liver disease increasing and the number of deaths increases. While this is almost in parallel for Italy, the projection is different for the UK due to the fact that the mean age of patients infected is relatively younger. So you'll see more patients advancing in disease with a relatively lesser number of deaths. But we are still in numbers of thousands of people with disease progression and thousands of deaths. If we try to project it at a global level, and this we did with the cooperation with Polaris Observatory, you'll see that if we try to model the 1 year in the global impact of delaying 1 year in HCV programming, relating it with the current status, no delays, current pre-COVID status, I would have to say, with no delay in treatment, you will see that between 2020 and 2030, delaying 1 year will miss almost 1 million new diagnoses, will cause a loss of 800,000 treatment, and instead, by converse, will increase the number of incident HCV cases, incident liver-related deaths, incident cancers, and certainly will leave the number of people with viremic infection around to be increased by at least 500,000. The impact will obviously be related to the global burden of HCV disease already existing in the region, with the highest toll in the American continent, but also in Australia. And if one tries to model this by different income countries, these are classified by World Bank income groups. Again, with the 1-year delay scenario, you might be tempted to think that it is mostly a problem of low or middle income countries. Absolutely not so. As you can say, even the so-called rich countries, the one in yellow, will see a very significant number of mistreatment, of excess incident HCV new cases, of excess cancers, and of excess liver-related deaths. So the proportions are more or less equally distributed, although with some variation, regardless of the income class of the country, which leads to thinking that COVID-19 is impacting hepatitis programs and the progress toward elimination, and certainly will, in the end, result in excess mortality due to HCV. And this is a clear indication for policymakers to try to prioritize hepatitis programming when it will become safe according to local situation to do so. In the end, we should also think that there are some COVID-related opportunities. Not everything is a disaster. In fact, COVID has led to increased testing capacities in many countries. Conceivably, although it is difficult, it is possible to combine COVID testing with HCV testing. There may be a decrease in stigma and increased acceptability in terms of caring and curing infectious diseases. And we might, to a degree, recycle a hepatitis program to deliver testing and to act as referral service for this sort of testing. Certainly, we have a number of opportunities lying behind, and the use of telemedicine is one of these opportunities. But I cannot close this talk without saying that the great lesson of COVID has been the need for simplification. Screening for HCV is easy. Treatment is easy and simple. We should try to strive and streamline the process and simplify the thing in order to make it feasible even at a time of hardship as the current COVID pandemics. Thank you for your attention.